A very good evening to everybody here. Thanks to AIOS for including this course. And a round of applause for all of you, because you are the true audience for corneal tattooing who will never give up till the end. So corneal tattooing is that procedure, and you are the perfect audience. Okay, so I will begin with the indications and the types of dye used for corneal tattooing. Cosmetics is important today, just as it has always been historically also, but more so now when a cosmetic defect in the eye is unacceptable and limits the quality of life in many patients. So when there is no hope of getting vision in that eye, at least there should be hope for aesthetics, and that will soften the blow in delivering the message to the patient. I will be speaking on the history of keratopigmentation or corneal tattooing, the indications, the contraindications, and the types of dye. The rest of the topics will be covered subsequently by the other speakers. It is nice to know a little bit of historical perspective, because we should know at least the names of the giants on whose shoulders we stand. So the Roman physician, the ancient Roman physician Galen, was the first doctor, the first physician who performed the first corneal tattooing in human history. He used, for unsightly corneal scarring, he used something called a pomegranate bark, and he covered the cornea with that bark to provide the tattooing. Several centuries, nothing was done, and after that came Dr. Samuel Ziegler. He is considered the father of modern keratopigmentation, and it is his protocols that we have built up on today. So he did an exhaustive body of work, and he actually wrote a book, Multicolor Tattooing of the Cornea, in which he has described not only the types of pigments, he has given exhaustive thesis on the types of colors which should be used, what mixed with what, the blue mixed with green gives a brown, and how much the pupil size should be. So he had done a huge body of work, and much of our keratopigmentation techniques now come from what we have developed upon that science. Much later, the oculoplastic surgeons, these are all names of people in history who have experimented with corneal tattooing. So Wecker's needle was a needle in which cocaine was used to anesthetize the eye, then a dye was spread on the cornea, and then it was embedded with the single, like you can see, there's a single stylet. So this was the Wecker's needle. Much later, Dr. Taylor decided that a bunch of needles was more efficient than a single needle. So in fact, that is the basis for the tattoo gun, which will also be described later by Dr. Mona. Then came other authors, von Hippels, then came other instruments. Slowly, by little, this procedure has evolved. So they made a dye, so they made a tubular tiftrifine to localize the dye onto the cornea, and then used a fountain pen or an electric needle to drive the dye into the cornea. So keratopigmentation has now been established as a safe surgical procedure that is easy to learn, easy to perform, does not require a lot of specialized instruments, and it avoids the extensive and invasive reconstructive ocular procedures like evisceration, enucleation that have to be done to provide cosmesis. So it is a kind of a semi-non-invasive kind of procedure. Corneal tattooing can be a procedure for long-term or permanent correction of cosmetic eye deformities in patients who suffer from scars like this. Now, what is the advantage or disadvantages? How does it compare with the cosmetic lens? Because these are the options that we provide to a patient when he presents for cosmesis. So we tell them you can use a prosthetic contact lens, but the problem with that is, till you're using it, you have the cosmesis. And when you take it off, it is white again. So in contrast, tattooing gives you a more permanent kind of solution. So with contact lenses, there is always an issue of hygiene and compliance issues, but with tattooing, there is no problem, there is no maintenance, because once it is done, it is done. You may need to repeat it in the future, but nothing on a daily basis. So as far as the indications go, it is very important to consider which cases are amenable, because case selection is what is important. So indications are divided into cosmetic indications and functional indications. So if there's something wrong with the cornea per se, if there is a corneal scar without anterior synechia, mind it. If there is an adherent leukoma without the iris peeking out, if there is cicatricial keratitis, or if the patient is just not willing for the daily hassle of cosmetic contact lens wear, then you go in for corneal tattooing. Then if there is a retrocorneal pathology, like the pupil is white, there is leukocoria, it's an end stage eye, there is no visual potential, but the eye is white, the girl is getting married, she wants cosmesis. So then tattooing is an option. And then if there are iris defects, iridia, then there is the coloboma, there is essential iris atrophy in which the glare is coming out and the patient wants relief from that, or it's causing some kind of shadowing or discomfort, then iris problems are also a reason to go ahead with tattooing. Recently, Dr. Halio, who has done extensive work on corneal tattooing, has also described a cosmetic indication. So this may be slightly controversial, but he has done it, and he has proven that purely cosmetic keratopigmentation has demonstrated stable long-term follow-up with no visual disability, high patient satisfaction, and favorable outcomes in all patients. So this should be offered to patients who want it just for cosmetic. It is a seeing eye, but you want it for cosmesis. Contraindications are when you should not do the procedure. This is what I was speaking about case selection. If there is a leaking cicatrix, then you know that your dye is never going to stay there. It is going to fade away. It is going to get washed away as it gets diluted by the tears. So if there is a synechia, if there is active inflammation in the eye, if there is iridocyclitis, if there is intractable inflammation, then the dye kind of gets phagocytosed by the corneal stroma, by the keratocyte, so it will fade away quickly. So there is no point in doing it repetitively again and again. If there is intractable glaucoma and that causes persistent corneal edema, that will also cause a loosening of the corneal epithelium. So the epithelium will keep breaking down and the patient will be as miserable as when he had presented to you. So the types of dye, even though it is true that since Gallen's time pigmentation has been known, it is now only that extensive research has been done on the type of modern dyes and pigments that can be tolerated by the eye and that give you a good cosmetic outcome. Again, if we go back historically to Ziegler, the pigments, he gave the characteristics of an ideal dye. So it should be able to mask intercept the light which is coming. It should be able to obscure the corneal scar. Mineral colors are more permanent than vegetable colors. Irritating pigments should not be deployed. So we have built upon that and we have categorized the modern pigments into 3 types. The first generation are the skin pigments which you use for your skin tattooing, either the liquid type or the powder type. The second generation are non-certified pigments and the third generation are cornea-specific pigments. So Dr. Ziegler had come up with a surgical protocol. So he had described that it is important, you're doing this for cosmesis. So it is important to match as much as possible the color of the tattooed eye to that of the healthy eye. So people have gone into really great detail and they have described what should be the size of the pupil, what should be the color of the iris surrounding it, the color of the striations in the iris. So that gives you a perfect cosmetic match with the other eye. And pigments which should be avoided are obviously the ones which cause irritation on the eye, such as cadmium, cobalt, and the ones which have a high rate of addition of chemical excipients. Disadvantages of the traditional metallic salts are that they are irritative to the eye, so they cause recurrent corneal erosions, corneal redness, and melt, and they fade away, so you need to repeat the procedure again and again. So this is where the micronized mineral pigments come into play because the metallic ones don't stay for so long. So once you kind of break down the size into very small particle size, 2.5 microns or less, then this can be driven into the stoma and it will stay there for a reasonable length of time. Another important advantage with these micronized pigments is that you get them in several colors, so you can mix them and get a whole array of colors to match the iris of match the color of the other eye. And it has been demonstrated that several studies have demonstrated that the corneal tolerance to these micronized inorganic pigments is quite good, and there are no inflammatory reactions. There were no kind of adverse reactions on the epithelium or the stroma. And even though the dye, in fact, they have shown that it stayed for 25 years or so within the keratocytes, and it caused no harm. As far as commercially available dyes go, you have Dr. Mahatme's powder, which was used, and the second is the India ink, which will be described later for use with the tattoo gun. And the third type, which has been shown, is the traditional type of soot powder, which is made in the operation theater by inverting a steel bowl onto a candle. So you build up a soot, and it is a kind of a homegrown measure to use it for disfiguring corneal opacities. So so you have these 2 types of dyes. Basically, one causes the chemical staining, which means that you use metallic dyes like the gold chloride, silver nitrate, and the platinum chloride. So as long as you get your dilutions right between 2 to 5%, you can use these pigments, and you can put hydrazine as a fixative, and this will give you, and you can play around with the match of the colors to give you the exact color which you want. And that will stay on the surface, and you can refrigerate these pigments and reconstitute them with distilled water. So whenever you need them, you autoclave it, bring it to the OT, and use this. These are the metallic dyes. And like I told you, they don't stay there for too long. The non-metallic dyes are the ones which are being used currently, India ink and titanium dioxide and all. And histopathology has shown that they stay in the intracellular, they stay in the keratocytes for a very long time. Other aspects to consider before you actually do the procedure is that all the contraindications should be taken care of. If there is an adherent leukoma and iris is stuck there, then a synechiectomy is suggested. If there is conjunctivitis, you take care of that. If there is an NLDO or lacrimal duct obstruction, then you need to do the probing and syringing before that. If there is thysis bulbi, that is a kind of a relative contraindication because the eye is in a kind of anophthalmic position. So they have described that you do a tenotomy of all the recti muscles and kind of make a compensating exophthalmos so that your eye comes out of the socket, and then you tattoo that. So extensive procedure, but it has been described. Most important is counseling. Counseling, like for every other procedure in ophthalmology, if the patient understands the advantages of what he is going in for, he is more likely to be compliant with the follow-up and understand that it may need to be required to be done again. And as far as the slit lamp examination and all goes, you need to measure you need to confirm the lack of visual acuity. The intraocular pressure should be within normal limits. And ASOCT we have described because you need to know if there are any areas of focal thinning. If there is an area of focal thinning and you go in with a tattoo gun, which is puncturing, you will enter the chamber and you will inject your dye inside. So these are the investigations which need to be done. So we can conclude that keratopigmentation achieves stable and satisfactory cosmetic results with very high patient satisfaction. Based on this idea, this systematic approach has been developed in the last 10 years mostly, so that what was an empirical thing earlier has now become an art and a science. So there has been great improvement in the surgical techniques. So we have much reliable, very advanced instruments now that deliver very consistent results, and there is high patient satisfaction. The complications which will be described, and like every procedure there are complications, they are likely related to the learning curve and mostly related to the patient selection. If you choose the patient in which you are doing this procedure correctly, then you will end up with less nightmares. And these are some of the results which will be shown later also. So, thank you.